A very good evening, everyone. Welcome back to our Iron Talks live webinar, where we've been discussing about iron and related issues. It's a pleasure to have every one of you all back again at the session. So, before we jump into the session, let me introduce our host for the night, Dr. Sanjay Kalra. Dr. Sanjay Kalra has done his DM endocrinology from AIMS, New Delhi. He's a past president from Endocrine Society of India. Dr. Sanjay Kalra is a president-elect South Asian Federation of Endocrine Societies. He's a board member for the International Society of Endocrinology. Dr. Sanjay Kalra is the president of Indian Professional Association of Transgender Health. He has a lot of achievements and accolades to his name. Dr. Sanjay Kalra serves on the Research Society of RSSDI, Research Society for Study of Diabetes in India. Dr. Sanjay Kalra has over 1,000 PubMed index articles to his name. He has fostered bilateral and multilateral links between various Afro-Asian countries in the field of endocrinology. Dr. Sanjay Kalra developed the term glucochronology and lipochronology and the glucocopper tool to assess coping mechanism. He is the winner of the 2009 Dawn Award, and Dr. Sanjay Kalra has served as an executive editor from 2011 to 2015, where he worked to establish the IJEM. IJEM was rated as India's second best scientific journal according to Google Metrics. Dr. Sanjay Kalra can be reached at his hospital where he practices in Karnal at Bharti Hospital. Sir, a very warm welcome and Jai Mata Di, sir. How are you, sir?
Sab Badhiya and Jai Mata Di. Jai Hind also. Today is a special day from a historical point of view, Mahatma Gandhi Jayanti, and also from a religious point of view. So we celebrate a very festive, very auspicious day today.
Absolutely.
Thank you, Karan, for hosting us today.
Right, sir. Thank you so much, sir. The stage is all yours.
And since it's a festive mood, all the more reason for us to thank everybody who is logged in today, all our colleagues, friends from across the country and beyond. There are so many things that you can choose to do on a Sunday evening. But the fact that you join Iron Talks means that iron actually means a lot to us. And today we have with us as our speaker, the Iron Man of Indian cardiology, Dr. Kamal Sharma. Dr. Saab is a cardiologist, senior interventional cardiologist at Ahmedabad, very good clinician, a teacher, researcher, and author as well. And Dr. Kamal, we are speaking of Iron Talks today, and we are speaking of anemia and the heart. Why would the heart, of all organs, why would the heart have any link with hemoglobin?
Hi, good evening. Thank you, Dr. Kalra, for having me. Thank you, FDC, for the opportunity. And as you said, iron and heart, and of course, वो जो कहते हैं आपको लोहा मानना पड़ेगा, तो आयरन का भी लोहा मानना पड़ेगा. बात ये है, so the reason is that I think ultimately oxygen delivery is what heart serves for. And for that, you need the blood not only to be pumped, but you also require hemoglobin to transport that oxygen. And for that, the very important cofactor is going to be iron. So even if your heart is pumping very efficiently and his ejection fraction is absolutely bang, super normal, but if you have anemia, we all know that it would lead to a high output cardiac failure. But what we also have now understood of late recently, couple of decades now, that even patients with iron deficiency but no anemia, means आपका hemoglobin तो अभी भी 10, 11, 12 है, लेकिन if you have hemoglobin so-called normal or high, low normal, but your iron levels are low, even then there is a worsening of heart failure and outcomes are bad. So this is a state that especially in patients with heart failure, if you have iron deficiency without anemia, even then your rates of hospitalization, worsening of heart failure, quality life, all of that suffer. Lot of it also comes from the oxidative stress and oxidative metabolism, for which like cytochrome oxidase or multiple other coenzymes which are required, the cofactor is iron. And that is very important for how efficiently heart can work and how efficiently tissues can utilize oxygen. So iron deficiency is not only for anemia, but Iron Talks means also beyond anemia, and that's what we are going to talk about. So we'll discuss for sure anemia, but I will also try to touch upon iron deficiency in absence of so-called full-blown anemia. So आपका hemoglobin 10, 11, 12 and Indian tendency है 10 से ऊपर है तो चलेगा. That how dangerous it can get. So that's why it's so important, Dr. Kalra, that you brought up this topic and involved a cardiologist. And a lot of people must be wondering what a cardiologist can suggest in our iron metabolism, especially. And this is a very important perspective that you chose this.
We all look up to cardiology actually, and there are multiple questions that will come your way. We welcome Dr. Javed Iqbal Khan, Dr. Vinay Desai, Dr. Sanjeev Puri, Dr. Yoglesh Uplenchwar, entire India listening to you, and many other questions will also come. We see so much of sudden cardiac death or sudden death these days. We read in the newspapers. Sometimes we blame it on COVID. Sometimes we blame it on other things. Maybe anemia is a culprit. So, Dr. Kamal, the stage is yours. We'd love to listen to you.
Thank you. And I can already see a couple of questions popping up. But before I move on to take questions that Dr. Sanjay would direct against me, I would like to build a background to set the things clear so that a few questions can also be cleared off rather than being flooded off with the questions directly. So, what I'm going to talk about is that we all know that anemia is the fifth cardiovascular risk. And I'm sure this is not the slide that you're seeing for the first time. A lot of people before me must have talked about this. And this is because of, as I said, complex interaction of iron deficiency, cytokine, renal impairment, blood loss, etc., contributing. Iron excess can also be detrimental. Now, basic examples that I gave is look at the koilonychia and platynechia that you find in iron deficiency anemia. You know why that happens? Because the nail growth at the bed is impaired because of iron deficiency anemia, deficiency leading to the cytochrome oxidase and the other enzymes not being able to generate enough amount of nail tissue, and that's why instead of bending forward, the amount of deficient nail gets into flattening. And this is something that you can see actually in nails, but there are things beyond what you can see, especially in the heart and the metabolism related tissues, which can actually manifest with the similar disorder with the stunting of their function. So not only is platynechia, koilonychia seen in iron deficiency, but it's also seen in iron excess when the enzymes are actually flooded and damaged and cannot actually work as efficiently in hemochromatosis, which is the other cause of platy or koilonychia, as we know. So data indicates that iron deficiency is detrimental for coronary artery disease, pulmonary hypertension, heart failure, post-cardiac surgery, and one-third of heart failure patients and more than half of the pulmonary hypertension actually have iron deficiency. So anemia treatment in cardiovascular disease, it lacks clear targets. There is undefined specific therapy, no clear guidelines currently available, and treatment with erythropoietin combination has also been given, especially in patients with CKD with iron deficiency. But there is one other important aspect. Trials with alpha erythropoietin analogs like alpha poietin and demopoietin actually failed to show improvement in outcomes in iron treated patients in heart failure without CKD. So this is something that goes on to tell you that erythropoietin, though may be a very lucrative option or alternative in heart failure, but it is not so yielding and not so important therapy as long as outcomes in at least heart failure is concerned. Now that's why iron is an important alternative and a better lucrative and evidence-based therapy to choose. Iron administration in iron deficiency, heart failure, and PAH leads to not only improvement in quality life and exercise capacity, but in recipients of cardiac transplant, they, however, should not be treated with iron deficiency because we don't want iron overload or T cell activation, which is common because T cells require iron for it. Now, we know that in heart failure, patients, the prevalence is pretty high. It is said that almost one third to one half of the heart failure patients actually have iron deficiency. And if you were to count with anemia, if you were to count iron deficiency without anemia in Indian setup, there is a paper from Rajasthan which tells its prevalence is as high as 70%. Anemia is an independent risk factor for the outcome of heart failure, and the combination of sub-Q therapy, though, has been erythropoietin with IV iron has been evaluated, but again, as I said, it's IV iron which holds the data, and edge erythropoietin data is not so strong. And this is that paper that I was talking about. You can see here how Sharma et al. From Rajasthan, that's not me, Sharma, that's some other Sharma, prevalence of 76% of iron deficiency, just 51% of anemia. And this actually is seen all across the countries from Southeast Asia. If you look at data from Singapore, almost 61%. If you look at data from Greece, Poland, and France, also the prevalence approaches 70s. So mechanism is multiple in heart failure. You have ventricular failure, you have reduced arterial flow, RAS activation, and also inflammatory cytokine, which leads to resistance of the erythropoietin. Also, utilization and is poorly utilized, and hence you have decreased RBC production with suppressed erythropoietin and erythropoietin production also contributing to RAS activation, contributing to dilutional anemia, which is because of increased plasma volume, and all these in turn lead to development of anemia. So but this is how the progression further. So anemia is found in 1/3 of heart failure, as I said, and prevalence of iron deficiency without anemia would be much higher, almost 2/3 of the patient. CKD is also present in half of the heart failure. So CKD, due to renal vasoconstriction, can accompany CHF and may cause long-standing renal ischemia, and this reduces the erythropoietin production also. So anemia can occur in heart failure without CKD. It may be because of excessive TNF alpha or IL-6 secretion, and it can worsen cardiac function, causing cardiac stress through tachycardia, increased stroke volume, and causing reduced renal flow, blood flow, and fluid retention with long-standing anemia, causing more CHF and damage to the kidneys, worsening the anemia and heart failure. So the diagnosis hence of heart failure, once it is made, the findings of iron deficiency anemia, anemia of chronic disease, and heart failure related iron deficiency can be differentiated based on looking at simple things: TIBC, ferritin, and iron. Though people can look at from the theoretical perspective for transferrin receptor and transferrin saturation, but in iron deficiency anemia, not only TIBC goes up, but serum iron ferritin would be low. Anemia of chronic disease, however, would have reduced TIBC because though ferritin, transferrin levels go down, saturation in all of them, the ferritin actually in a chronic state as an inflammatory marker, ferritin can actually be elevated. And those serum iron are depleted in all. And heart failure related anemia with iron deficiency also would have TIBC, which is normal or raised, but ferritin level is increased as compared to serum iron. So simply looking at ferritin and TIBC, if you think that the cost is exorbitantly high, but the good thing is that COVID has taught us now how to utilize ferritin. You just need to add TIBC. You may not look at serum iron if you find a patient who has already got anemia, and just from the peripheral smear you can pick it up. But ideally you would go through all three of them, and that would make you aware of what you're dealing with, whether it's iron deficiency anemia, anemia of chronic disease, or it's a heart failure related anemia with iron deficiency in the patient. So there can be two types of iron deficiency, what's called as absolute and functional, where you just look at ferritin. If it's less than 100, it's absolute. Between 100 to 300, you call it functional. And of course, TSAT, as it is called, transferrin saturation, if it's less than 20%, you call it functional deficiency, while TSAT is decreased, but the level does not contribute to diagnosis, and absolute. And marrow would, of course, show absence of iron granules, which may be considered as gold standard. So functional ID has been found to be more common in earlier stages of heart failure with absolute iron deficiency as the disease progresses. So you treat them with IV iron, and if required, erythropoietin and other agents. But studies have shown that early correction of CHF anemia and sub-Q EPO with the IV iron improves shortness of breath, fatigue, cardiac function, renal function, exercise capacity, and need to hospitalization being reduced. Again, in coronary artery disease, they have been shown that low hematocrit values are associated with higher 30-day mortality, and transfusion might improve outcomes in elderly who have anemia and suffered myocardial infarction. So target, and there are papers from regression analysis, anything below 10 surely increases compared to those with hemoglobin more than 10 to mortality being twice if your HB is less than 10 in doing in acute patients. This is a very important trial I thought I should discuss with you called Confirm HF, where they firstly were able to establish how the IV iron changes the outcome, published in 2015, where 6-minute change in the distance that a patient can walk was considered as a therapy goal as the primary endpoint. And heart failure patients included patients with EF of less than 45. So these are not severe airway dysfunction only. Anybody who's got EF of say 40, 45, up to 45, and has got iron deficiency without full-blown anemia. So ferritin level is low, and if it's between 100 to 300, transferrin saturation is low. In that case, if you give them iron, There is improvement in 6-minute walk test, and also the need for hospitalization for heart failure is reduced statistically much significantly. So symptomatic iron deficiency heart failure with FCM over a year resulted in sustainable improvement in functional capacity, symptoms, quality life, and reduction in hospitalization for heart failure. There is now trial all across the spectrum for congestive heart failure and iron. So you have symptom, quality life, function, morbidity, mortality trials. You have FAIR HF, Confirm HF, Effect HF, and Affirm HF. Now this is very important. Affirm HF is actually a trial in acute heart failure, and it was recently published. And this is one of the therapies that has been now proven to be significant in acute heart failure for improvement of symptom quality and functional life. Not many therapies. आप जो standard therapy use करते हो, say now the newer therapies, SGLT2. Now the trials are emerging like Impulse for using those therapy in acute heart failure. But FRMHF is one trial which is actually now established IV iron in acute heart failure also. So these are the 4 trials which have looked at, and now we have morbidity mortality trials also ongoing, and these trials are expected to come by 2023. FAIR HF2, Heart Fit trial, FAIR HF, Practice ASUS trial, etc. And this would make it, what we call as pillar of heart failure treatment. ऐसा बोलते हैं 4 pillars होते हैं: बीटा ब्लॉकर, एस एआरबी और आरनी, SGLT2 and MRA. ये 4 तो आपके pillars थे. Now people are talking about one more pillar, the 5th pillar, which may be IV iron in this seconds. And when you look at the guidelines, it's very clear. Class 2A guideline: in patients with reduced ejection fraction, iron deficiency with or without anemia, both group of patients, IV iron replacement is reasonable to improve functional status and quality life. Only and compare this with erythropoietin stimulating agents, they are not so important, and they actually end up in class 3 recommendation. So ferric carboxymaltose is used and it's available. It suggests improvement in symptomatic iron deficiency with benefits across improvement in functional quality of life, improvement in symptom, and reduction in admission for heart failure worsening. So anemia is an independent risk factor all across the spectrum of heart cardiovascular disease, including such as left ventricular hypertrophy, CKD, heart failure, and competing risk may be at play. Anemia itself may result in ventricular remodeling, LV dilatation, as we know, high output heart failure also. And it has shown, IV iron therapy has shown a promising result that there's a dearth of control data in terms of morbidity, mortality. But combination therapy may provide a reasonable solution, and both heart failure, end-stage kidney disease are rapidly progressing and increasing. The twin condition may be improved by correction of anemia, and also iron deficiency without anemia to slow the progression of both the conditions. So I thought that I will share this evidence at least to make you all aware that it's iron is not just about anemia, but even in deficiency without anemia and heart failure. This is one place where the therapy holds a lot of promise. Thank you very much. Over to Dr. Kalra.
Thank you, Dr. Kamal. A very concise but a comprehensive insight into the link between anemia and heart disease. And I'm reminded of an English word, the quadriga. Quadriga means a chariot that is run by 4 horses. So the 4 horses of heart disease are actually the dhol that we struggle with actually in metabolic clinics. D for diabetes, H for high blood pressure, O for obesity, and L for lipids. These are the 4 horses which run the chariot of heart health or heart disease. And the 5th horse that Dr. Kamal has added today is iron. तो जो पांचवा घोड़ा है डॉक्टर कमल, out of all these 5 horses, of course you have to ride all of them, you have to take care of them as a good charioteer in the OPD, but which is the toughest, which is the easiest out of these 5?
Yeah, I think easiest to ride would be SGLT2. कोई प्रॉब्लम ही नहीं है आपको, कोई साइड इफेक्ट नहीं है. अगर आपको डायबिटीज नहीं है तो बहुत ही सिंपल थेरेपी हो गई. अभी तो SGLT2 हैज गॉट सच अ पिलर इन टर्म्स ऑफ डिफिकल्ट टू ट्रीट. आप बोलते हो तो डायबिटीज जरूर है क्योंकि इट रिक्वायर्स कॉम्प्लेक्सिटी ऑफ मैनेजमेंट. लेकिन अगर आप उसको ट्रीटमेंट पर्सपेक्टिव से सोचो कि विच इज इजियर टू गिव फ्रॉम अ कार्डियोलॉजिस्ट पर्सपेक्टिव इफ देयर इज नो डायबिटीज, द थेरेपी वाइज व्हेन आई वाज टॉकिंग ऑफ 4 पिलर्स, द 4 chariot, 4 horses that will run: SGLT2, MRA, ARB, or beta blocker. So SGLT2 for a cardiologist is pretty easy to start in terms of if the patient does not have diabetes. Diabetes, and then the game changes. Difficult would be, how to up titrate in a patient of heart failure beta blockers to reach to the optimal goal. वो नहीं होता है. Lot of times I see even cardiologists struggling to go up to that. But now when you bring the fifth horse in, which is anemia, then I think that becomes much easier to treat, because आपको SGLT to the lifelong लेनी है. Probably the data that exists now is 3 years, 5 years, based on which trial you're looking at. But for iron therapy, the outcomes that are for up to 1 year are based on one or maybe the just two injections. आपने outpatient basis पे, not, you don't even have to endure the patient. Outpatient basis पे, you give them the correction of iron deficiency based on the charts that we have, according to the weight and the deficiency of hemoglobin, or the iron levels. And then once you give 1000 or 1500 of the FCM, the outcomes improve over a period of time as early as 4 weeks, and they are sustained up to a year. So that's much easier when you consider it as the fifth horse. Otherwise, as you said, things would differ as to where the patient presents to. If the patient presents to me and is diabetic, it may be a bit difficult, because you'll have to think of GLP-1, you'll have to think of SGLT2, and then think of SUs not to bring or to bring, take off glitazones, add metformin, what amount acidosis, etc., etc., and then you'll have to interplay with the diabetologist. But for FCM is one therapy that can be given right from a general practitioner in the outpatient basis. It's like fill it, shut it, forget it. So as the
Forget it.
old saying went, तो आपने एक बार डाला, उसको बंद किया और भूल जाओ, फिर 1 साल गए.
Dr. Javed Iqbal Khan joins the discussion and he says, Daksa, anemia can cause heart failure or it can precipitate heart failure. But managing anemia can also precipitate heart failure. What is the potential damage that can occur? Let us say if I give 4 units of BT together in half an hour.
No, that's devastating. Maybe in heart failure, actually, you'll have to pretty go slow. And so that's the advantage that ferric carboxymaltose has. You can transfuse the total 1000 milligrams of it in over 30 minutes to 1 hour quickly on outpatient patients and send the patient home. So unless your iron deficiency is exorbitantly severe and patient has come with, hemoglobin like 5, you would do think of putting them on IV, of replacing and correcting anemia with PCV. But otherwise, when I say a patient comes with hemoglobin of say 8 or 9, and you don't want to be risking and taking a chance of pushing in the PCV, it's a stable chronic anemia, not the acute one. And if you consider Bohr effect, as we call 2,3-DPG, shifting the oxygen dissociation curve, if you remember your first MBBS of physiology, where heart is already getting good delivery of O2 because of the shift of the curve by 2,3-DPG, shifting the oxygen delivery much easier by Bohr effect. In that case, probably chasing the hemoglobin values by pushing in the PCVs is not a great idea, especially where heart is not in a capacity to take that extra volume of 500 ml of volume of PCV or 350 ml of volume of PCV to be loaded in the acute hospitalization phase. So I think you'll have to consider it overall in the clinical scenario. And I think in a borderline case, FCM would be good choice, though you can accept a clinical response easier if the patient has got much acute and a severe anemia with PCV. But otherwise, if it's a chronic and slow and mild to moderate anemia, and if it's surely iron deficiency only, then good idea would be to give them FCM.
So that puts things in perspective. So Dr. Javed points out that 1 unit of blood contains 200 milligram of iron, or roughly 1 ml of blood contains half a milligram of iron. So the onset of action of blood transfusion, like Dr. Kamal said, would be faster but you will use it only if it is acute blood loss, acute anemia, and symptomatic anemia. And if it's a overall chronic stable patient, then maybe ferric carboxymaltose would be safer. You can also use iron sucrose if you want, because carboxymaltose is a bit expensive. Yeah, and that also
True.
you can use in a very small volume of fluid. So it
True.
depends upon how, on what kind of a response you want. Do you just want the hemoglobin to go up, or do you want symptoms to improve? Do you want long-term improvement in heart outcomes, in cardiovascular outcomes? But thanks,
True.
Dr. Javed, for raising this and telling us to look at the pros and cons of everything before prescribing. One question I will take from Dr. Vinay Desai. Patient on premix shifted to basal bolus. So Novorapid or rapid acting total is 8 into 3, 24 units. Basalog or Glargine, 25 units at night. So that is a very good distribution, 50-50 between basal and rapid. That is right. But fasting is still 150. PP is 370. For fasting, what we should tell the patient is that first you will begin to feel better. You will get symptomatic relief first with basal bolus. You will begin to feel better. Then the postprandial glucose will come down, and then the fasting. So glargine may take 2 or 3 days to act. We don't need to increase the dose every day. We can increase at the most twice a week. Now the postprandial excursion is 210. So either the Novorapid is not working at all, 8 units, that is difficult to imagine. We need to know the weight of the patient as well. Or there is something wrong in the diet, or maybe there is an occult infection which we have missed out. So we can add acarbose, we can add metformin to this patient. But do look for an occult infection. Also look for timing. Novorapid can be given 5 minutes before, immediately before a meal. Had it been rapid acting insulin human, then we would have had to give 30 minutes before a meal. Other questions also coming in. So Dr. Nitin Narula asks, hemoglobin is good, but iron levels are low. That's what you've talked about. Theoretically, we will call it subclinical iron deficiency, but it is not subclinical because, like Dr. Kamal said, the clinical manifestations are gross. You just have to look for them. And Dr. Nitin says, can I give oral iron? Will that suffice?
Yeah, so good question. So if you ask me, is it good? I mean, see, iron deficiency needs to be corrected. That's for sure. You may have, see, it's like iron is required to create. I mean, if you think in physiological terms, iron would be required to create hemoglobin. That's fine. But you will also have some storage for emergency purposes, which comes in ferritin, a Persian blue stains that you do for a marrow. You will be able to see iron stores. So iron also needs to be stored. It's not always that all the iron will go into hemoglobin directly. So when you are not able to do they replace the iron adequately, not only it's not utilized properly for creation of more hemoglobin, but also, as I said, it's not going to be available for other coenzymes and cofactors as it is in, say, cytochrome oxidase or the enzymes of the mitochondrial function. And mitochondria requires a lot of iron as a cofactor, and mitochondria is present in as the energy house of a lot of cells, not just heart. And that's the reason that you'll require iron to be replenished adequately despite hemoglobin being so-called normal. So first state would be iron deficiency, and then later on only you'll be able to get iron deficiency anemia. And for that, if you ask me from heart failure perspective, evidence is right now only for IV. But for the theoretical purpose, if you're not talking about any iron deficiency anemia associated with heart failure, I think oral iron in long-term perspective should also be able to give you the similar clinical results. But again, if you ask me for heart failure alone, it has to go be with IV because the trials are not there for oral, and to design a trial with oral would be more expensive than the whole therapy, being given to the patient. So probably that's why probably we'll never get a trial in that direction.
It'll take longer also to act the oral iron, and
Absolutely.
heart failure
Absolutely.
is actually an emergency. Even if the patient comes to your OPD and you feel it's not an emergency, Dr. Kamal, is this right? Patient can come to you in the morning in the OPD, walk in and walk out, and in the night he is there in emergency, gasping for breath and asking for admission. Does that happen commonly?
Yes, it's pretty common. So when your sympathetic tone is withdrawal in heart failure, which very often the mechanism explained in, say, paroxysmal nocturnal dyspnea, that may be the mechanism. So at night, patient may be not only be off the trough levels of the drugs, it will also have the withdrawal of the sympathetic tone. So patient can come at the middle of the night. There might be surges in the night, nocturnal surge in blood pressure, heart rate, fluctuations in blood sugar if the patient is diabetic, a drug level, body temperature variations, room temperature variation or atmospheric temperature variation. All of them can trigger even arrhythmias that can trigger ischemias, platelet aggregability, viscosity of the blood. All these can contribute in a patient who was previously stable to come with a worsening of heart failure at middle of the night. So these patients are actually working at the peak of their Frank-Starling curve, as we know from physiological perspective. Heart is working at the peak of the efficiency, and just you need a small push and then you end up with a failure. So that's the aspect that you must understand, and that's why you need to make every pillar strong. Your building is hanging on by fire, on hanging by a line, by a thread of on the borderline of getting into a worsening of heart failure, and you have to make each pillar strong. You have to make even the iron pillar strong by correcting his iron deficiency, not just anemia.
Dr. Manoj Kumar Tripathi and Dr. Nitin Narula continue the discussion. And the point is that we should respect the WHO definition of anemia. WHO says that normal hemoglobin is more than 12 in women, more than 13 in men. And it does not discriminate between Indians and Pakistanis and Europeans. So if you respect the WHO definition And then you respect your laboratory, wherever your test is being done, that will automatically tell you which patients have to be given oral iron. And of course, if you are worried about heart failure or if there is something symptomatic, then IV is always there. Transference saturation, TSAT is a nice way of deciding whether to give IV or not. If the TSAT is very low, then you can counsel your patient quite confidently that it will take ages for oral iron to act. So we might as well give you the IV and then get over with it for 6 months, 1 year. Sir, more
True.
questions
I
coming
think
up.
13.5 is the cutoff where the trials have been done with iron IV
Yeah.
and EF of 45. So, I mean, if you look at the other things like, I mean, beta blockers or ACE inhibitors, ARB, or even say for SGLT2, initially the trials were cut off at 40, etc. The mid-range, what we call now 45%, is it's up to that extent that IV iron has been evaluated, and it's been evaluated up to hemoglobin of 13.5. Patients had hemoglobin of 13 but had serum iron level or ferritin level or TSATs which were in the range of what is defined as iron deficiency anemia, iron deficiency without anemia, and even those patients were included in all these trials and they actually benefited. So that's why I keep on stressing that hemoglobin alone may not be a good way of looking at iron deficiency status, as you very clearly pointed out, and as our participants also mentioned about the same.
Dr. Sanjeev Puri from Hoshiarpur in Punjab shares a clinical case, a challenging case. So let's dissect this one by one, Dr. Puri, and thanks for sharing this. 66-year-old gentleman with type 2 diabetes. He is on premixed insulin. So let us look at the cardiac and the vascular aspects. Dr. Kamal, cardiac as well as vascular both. He has pedal edema. He also has a wound on the left leg. We are not sure whether the pedal edema is bilateral or is limited just to the left leg. So what would that tell you, Dr. Kamal? That's one question. ECG and echo are normal. Does this tell us, Dr. Kamal, that the patient is CV safe and the patient has no CV disease? Or is it insufficient? He's 66-year-old gentleman with type 2 diabetes. Then his anemia, hemoglobin is 7.6. So the question from Dr. Puri is how to manage all aspects. Let us limit ourselves to cardiac and vascular. In vascular, we will request Dr. Kamal to talk about both venous and arterial. This particular patient in front of you, Dr. Kamal, what other information do you want? How would you want to help
Yeah,
Dr. Puri?
so very interesting case. So we need to also look at duration of diabetes, kind of medication that he is on, what is his EGFR, has he developed diabetic kidney disease, has he developed diabetic heart failure, diabetic cardiomyopathy. If the diabetes is say more than 10 years, then the likelihood of associated atherosclerotic event rate goes as high as 60 to 70%. If you have a non-healing ulcer, the likelihood of associated PVD or even for that matter, chronic venous insufficiency or deep vein thrombosis also needs to be excluded. As Dr. Kalra mentioned, you need to know whether it's unilateral or bilateral. But surely for a diabetic who comes with an ulcer in the foot, with edema or without edema, I would be interested in lowering the arterial and venous status of the patient. Atherosclerosis hence would make it, if the patient has got PVD, has got a peripheral arterial disease, it would make it more eminent because 20 to 35% of patients in various series that you're looking at, a patient with PVD is also likely to hold a coronary artery disease. And if the coronary artery disease exists, 50% of coronary artery disease in a chronic state in a patient of diabetes would also have heart failure. So I think you're dealing with multitude of disorders in this patient. I would be evaluating primarily for looking not only for the peripheral vascular disease, but again, a normal echo would not necessarily rule out a preserved ejection fraction heart failure unless it's done really by an expert and you've looked at E by E prime, you've looked at the other aspects to confirm that you've ruled out diastolic heart failure, say LA indices, as we know. So you can have a preserved ejection fraction with hemoglobin of 7.7. Now, again, what would be interesting with the 7-gram hemoglobin, what kind of functional status the patient is in. Is he class 3 or 4? In which case you would be interested, as we discussed, with correction with PCV if it's if the patient is acutely symptomatic and the drop is an acute one. If it's a chronic one and if his creatinine and EGFR is normal, that means it's not a CKD related and it's a chronic anemia, then you can still try to optimize his heart failure therapy and try to give him iron correction based on the iron profile.
Thanks. And we'll continue with the rest of your question, Dr. Puri. So when you have a patient like this, your question is, how do I manage all aspects? Now, what has the patient come with? The patient has probably come with that ulcer, that left leg ulcer. So when you're managing the ulcer, a few things to look at. Number one, vascular health. Dr. Kamal has spoken about that. Number two, neurological health. Is there a neuropathy? If so, try to correct that. Number three, infection. You have to fix that. Aerobic, anaerobic, gram positive, gram negative, medical, uh, surgical, superficial, surgical, deep, all that you have to look at. But none of these are going to work if you do not achieve good glycemic control. So the four aspects to look at from the leg point of view, from the wound point of view, will be vascular, neurological, infection, and glycemic control. In vascular, do not forget the veins. It can be deep vein thrombosis, it can be cellulitis, it can be peripheral arterial disease. Now, that is one aspect, but you're not treating the leg, you're treating the gentleman. So we need nutritional optimization. Anemia is part of that, and we'll shortly speak of hidden hunger, and we'll ask Dr. Kamal what hidden hunger means from a cardio perspective. So, nutritional optimization. In nutrition, you have macronutrients, micronutrients, and also hydration, that is mega nutrients. Water is a mega nutrient. Macronutrient, you are aware of protein and energy. Micronutrient is vitamins and minerals. Example vitamin D, example iron. And in mega nutrients, when you say hydration, you are speaking of hydration and also electrolytes. So this is an easy way to remember, 3 into 2. Medical optimization is required. Renal, hepatic, cardiac. This is the 3 that we look at, and pulmonary you might wish to add. And then the last one, but not the least important, would be endocrine. There is edema. It might be Cushing's. It might be thyroid. So, but if you follow this process in your mind, nutritional, medical, endocrine, and also psychological, this helps you go stepwise. You will not make any mistake. It's just like proving a theorem when you're in mathematics. So, Dr. Kamal, let's come back to hidden hunger. Traditionally, how hidden hunger is defined in metabolism is micronutrient deficiency. And they speak of vitamins and then they speak of minerals like iron, calcium. But what we are suggesting now is that the third aspect should be added, that is hydration and electrolytes. Too much of sodium, too little of sodium. So, keeping this definition in mind, from a cardiology perspective, how does hidden hunger impact your patients? And how do you unhide this hidden hunger?
So true. Very important aspect that you brought out. If you look at let me come to each of them one by one. So let's look at water first. A lot of times, a lot of patients of heart failure are told that वो आपको 1 लीटर पानी पीना है, 1.5 लीटर पानी पीना है. This can be sometimes be very dangerous because this can lead to a pre-renal azotemia. I tell my patients, unless you're in class 4 decompensated, grossly edematous, hospitalized, you don't have to follow water restrictions. Simple reason being that we are not fishes that we take water from mouth and gills it comes out. We have a good regulated, unless it is maladaptive, a thirst mechanism which is given based on our osmolality. So chemoreceptors and the mechanoreceptors, they are very much able to regulate the water intake based on your thirst mechanism. Overhydration, of course, is going to give its own trouble, but underhydration in heart failure in patients who are already on diuretics, SGLT2, loop, MRA, ACE, and you don't take good amount of hydration, can lead to actually pre-renal azotemia, worsening of heart failure, and development of hyperkalemia, and then a lot of side effects. So it's very important that unless patient is decompensated, in class 4 grossly edematous, you don't do a very rigorous strict class 1 liter se zyada nahi peena kind of water restriction to your patients. I don't allow that for my class 3 patients or class 2 patients at all. I tell them जबरदस्ती पानी नहीं पीना है, प्यास लगे उतना जरूर पीजिए, कोशिश करिए 1.5 से 2 लीटर से ऊपर एक्सीड ना करें, पर प्यास लगती है जब भी पसीना ज्यादा है, you have to take. Coming to micronutrients and vitamins, B12, D3, both have a lot of papers now emerging from cardiovascular health perspective, where patients can actually have worsening of heart failure, especially vitamin D. There's a lot of literature. People have reviewed it across left and right. In COVID cardiomyopathy, myocarditis, acute heart failure, sarcoid, amyloid, diabetic kidney disease, diabetic heart failure, coronary artery disease, coronary artery calcification. There is multitude of papers to talk about, and you just search vitamin D and cardiovascular health. There is so much of publication that's happening. I'm sometimes surprised that despite so many papers, it's still not fallen into class 1 or class 2A kind of recommendation yet. Coming to micronutrients, manganese, cobalt are two important other minerals or micronutrients that have a very important aspect in cardiovascular health. Not only in cardiovascular health, but also in a lot of terms in terms of anemia. We know there is a disorder called Keshan cardiomyopathy, which was found in Keshan province in China, which was primarily deficiency of these micronutrients, which led to cardiomyopathy. So Keshan cardiomyopathy is just an example to talk about how micronutrients play an important role in cardiovascular metabolism. I think iron is just the tip of the iceberg. You need multitude of minerals which can be cofactors in a lot of enzymes, and you need to be actually regulating the energetics at the level of cellular mechanisms that may be more important than just the efficiency that we look in anatomy perspective. A lot of patients we see whose ejection fraction is same. एक पेशेंट आप 15% वाला देखते हैं चलता फिरता है, एंड यू सी अदर पेशेंट उसका 25-30% है लेकिन ही इज डीकॉम्पेंसेटेड. Why this difference exists? Same amount of LV size, same amount of LV volume, different ejection fractions, different or similar cardiovascular outcomes, or maybe same hemoglobin, same diabetes control, and still patients are more symptomatic as compared to the others. I think it's got to do a lot of with the cellular energetics that may come into play, and that's the hypothesis that people are talking about for SGLT2. They say it regulates at the level of the mitochondria. They are talking about NG1 and 2, NG1 to 7, how it can be influential in the myocardial energetics, especially of the cardiac myocytes, in improving the efficiency. It's not just about volume depletion. Otherwise, वो तो diuretics भी करते हैं. और actually not only the intravascular volume, diuretics तो सारा ही volume निकालते हैं interstitium से. तो भी you don't get CV outcome benefits. But when you give SGLT2, it does not deplete intravascular volume. Only the interstitial fluid is going, but improvement in outcomes. And why would that happen? So probably energetics do come into play. And with the same hypothesis, I believe that micronutrients, vitamins, and of course, as he mentioned, the water itself are important aspects, as Dr. Kalra said, that we need to consider, especially, and these factors, who will look at it? From the cardiovascular point of view, the cardiologist का वो oculostenotic reflex बोलते हैं हम. उसको वो आर्टरी दिखती है, उसको एलवी दिखता है. डायबिटीज में, आई मीन आई एम नॉट सेइंग अबाउट एवरीबॉडी, डायबिटीज में ज्यादातर डायबिटोलॉजिस्ट को HbA1c, FBS और PPBS दिखता है. ज्यादातर आजकल CGM दिखता है, टाइम इन रेंज दिख जाता है. बाकी न्यूट्रिएंट्स कौन देखता है? So those things will have to come at the level of the family physician, will have to come at the level of physicians. And of course, we need to teach this to the super specialists, because super specialists don't cease to lose their MBBS degree. You are also a GP. You must know at least that amount of general medicine, which is expected of you for the degree which you got, which is still registered with the Medical Council of India. So for that purpose, everybody, even every specialist must be some amount of generalist. He should not forget it. But a family physician and an MD will have to consider, and that's a good thing that I've seen in my part of the world. Every physician or a general practitioner does focus upon macro and micronutrients, but this is something that is missing at the level of super specialty. So good that Dr. Kalra brought this out.
No, good that you called a spade and you called a mugdar. And Dr. Kamal, salam to you from Lahore. Dr. Altaf Chima has joined us. He is a very dynamic physician there. And also good evening from Bhillai, Chhattisgarh. Dr. Anshul Singh is with us. So the point is here is that micronutrients, they may be called micro, but they are important. And it is everybody's responsibility. हम सबकी responsibility है. Otherwise क्या होता है? You end up treating micronutrient health as the Draupadi of medicine. It is everybody's responsibility, but nobody takes care of it. And if the treatment is to write a vitamin or an iron tablet, then that should be done. If the treatment is to ensure adequate hydration, then that should be done by everybody. Dr. Pradeep Raval from Ujjain also joins us. CKD, heart failure, empagliflozin, DAPA. Dr. Anshul, if you allow, we will leave that for a separate discussion. We continue with the questions. Nitin Narula ji पूछते हैं vitamins for iron absorption. Vitamin C would be a good idea, better than D. And Dr. Kamal, Dr. Divya Rani has this question. Let's try to help her out. Hemoglobin 12, which is lower side. MCV 79.4, which is almost okay. Normal is 82, 100. MCH 25.7. Normal is about 30 to 30, 27 to 30-ish. REW borderline, fasting glucose borderline 105. And the daughter is age 26. She has had COVID thrice. So our question is, does this 26-year-old lady deserve an iron studies or not?
Yes, absolutely, because you may be dealing with a thal minor trait. Though you would expect hemoglobin to be in the range of 10 to 12, but when you do find these kind of a picture, I think doing a serum ferritin level or TIBC would settle the scores. You will be very sure that you're dealing with, a lot of times we in cardiology see patients with thal trait. So they are thalassemia minor, their hemoglobins would hang around 10 or 11 or maybe sometimes 9. And then you keep on chasing them with iron, they are not going to improve at all, and they don't have any bleeding history. And then retrospectively, you end up realizing, which may be not a good idea to be pushing in iron in these patients. But I think 12, as she mentioned, probably is the way the picture is looking right now, with an RDW slightly higher, which we all know as Menzer index, which we all know how it is calculated. It's something that your pathologist would be able to give you. Higher the RDW, MCV square divided by RDW multiplied by 100. If I'm correct, Dr. Kalra can correct me if I'm mistaking it out. There are a couple of indices to simply look at that and not do a TIBC and be able to pick up the sensitivity of Thal minor from iron deficiency. But I think rather than getting lost in the 5 or 7% of false positives and negatives of Menzer indexes, good idea is to do iron study and then think about whether you're not missing out on some other cause.
Yeah. So, madam, what I would suggest is hemoglobin electrophoresis and also an iron studies, and this should sort the issue. From an endocrine perspective, at any age, TTG to screen for celiac disease. But don't do that as a first line, please. Just do the hemoglobin electrophoresis and the iron studies. And if the iron is low, then Dr. Kamal has already mentioned intravenous iron would be a good idea. Dr. Gangadhar Rath has another question. Dr. Kamal, would you like to take this? Which insulin to use in steroid-induced hyperglycemia? You can use any
Dr.
one.
Kalra, when he's around, I think he should be the one answering this.
So both human and analog will be fine, but you have to use something in the afternoon, because if you're giving prednisolone or methylprednisolone, the highest glucose levels, Dr. Rath, will be in the afternoon or in the evening, post lunch and pre-dinner. So you cannot get away with premixed insulin. You will have to give something at lunchtime. In case glucose levels are not very high, still you will have to give maybe metformin plus acarbose or metformin plus repaglinide at lunchtime. If you want a very cheap drug, that will be metformin plus glipizide with lunch. But then there will be a risk of hypoglycemia post dinner, late night, because again you will be giving premixed dinner at night. So be careful with glipizide, but it is a 1 rupee tablet. Ideal would be acarbose. This question for you, Dr. Kamal. Patient has stress diabetes. Patient gets admitted in ICU with you. Sometimes he has hyperglycemia, other times doesn't have. So what do you do in the ICU? Are you giving metformin these days in the ICU, or is it a blanket no?
No. So that's a good question. So when you ask me from a cardiovascular perspective, when a patient is in ICU, very often I think I'm dealing with a CV disease, and that's the kind of patients that I see. So in that subset of patients, I do give them metformin at the time if the patient is not decompensated, not acidotic at the time of discharge. That's the thing that we choose. If it's an acute stress, then of course, as the good old saying goes, that you need to, these patients are insulin depleted. You will have to probably in insulinopenia replace them with an insulin. But at the time of discharge, most of these patients would end up on SGLT2 and metformin. Now we have data emerging from MPulse, which talks about empagliflozin in acute hospitalization and heart failure, and it has shown that there is a good amount of prevention of rehospitalization in ICU for worsening of heart failure. But again, most of the trials, as you know, the previous good old trials, apart from MPulse, did not include patients admitted in the acute ICU. So I think it's still pretty much an open and a gray area. But I strongly believe in therapy like SGLT2 at the time of discharge if your patient is not insulinopenic and not dehydrated. Primarily because in DARE 19 trial, which looked at, I think Dr. Kalra was also part of the team of the investigators, where I was also an investigator, that if you could evaluate dapagliflozin in COVID pneumonia, and you did not find any worsening of heart failure or euglycemic ketosis or insulinopenic kind of state, I think there is no other condition that you can actually think of, withholding if the patient is not insulinopenic, this kind of a therapy. But again, as I said, this is my belief, not evidence-based. Evidence is only from the MPulse trial, where SGLT2 can actually chip in, and I see that probably coming in as strongly as metformin. Again, which Dr. Kalra mentioned, that in acute hospitalization, you would be a bit hesitant to hold metformin and think of insulin in the acute phase. But at the time of discharge, as the point is trying to bring out, that you can always consider metformin.
Thanks. We go back to Dr. Vinay Desai's question. So the weight was 70 kg. That means, Dr. Vinay, you can comfortably go up to 70 units of insulin a day, divide into half. You've already done the right division. So maybe the glargine can go up to 30, 35 units at night. 30 should be fine. and 35 units of regular insulin. So we can make that 12, 12, 12, 3 times a day. Glucose levels should come down. Do try to rule out occult infection. The commonest would be urinary tract and genital tract, which we miss out. Dr. Altaf Chima shares that in chronic kidney disease, teneligliptin is a good choice, and that is right. And Love Humanity says C-peptide is normal, but HbA1c is 8.3. So usually C-peptide doesn't need to be done, honestly, Dr. What would be the best choice drug? Age is 55. So at 8.3 HbA1c, you will need minimum dual therapy, minimum. You will not be able to manage with metformin alone. So age 55, depending upon the weight, depending upon cardiovascular health, it might be metformin plus SGLT2 inhibitor. It might be metformin plus DPP4 inhibitor. If you want safety first, DPP4 inhibitor plus metformin, no hypo. Patient is coming from upcountry, he cannot come back to you for 3 months. No chance of monitoring. DPP4 inhibitor is drug of choice. Patient is worried about heart disease, or you are worried about heart disease, kidney disease, then it should be metformin plus SGLT2 inhibitor. If glucose levels come to normal, fine. Otherwise, after a month or so, you add the third drug, which will be the other one, the DPP4 or the SGLT2, which you had not added earlier. Sickle cell anemia, hemoglobin 4 gram, Dr. Puri. I would refer to the hematologist. I don't know what Dr. Kamal would do.
Yeah, I think so, because 40-year-old, I mean, if it's a sickle trait, that's more likely, because 40-year survival in an untreated and newly diagnosed 40-year-old with 4 gram hemoglobin, if it's a newly diagnosed, is more likely to be trait, because undiagnosed 40-year-old sickle is pretty unlikely. But otherwise, if it's a diagnosed case who's undergone a splenectomy and is N40 and still is having, I think you need to refer to a hematologist, whether the patient needs splenectomy, vaccination prior to it, etc., etc., will have to be considered.
And the other thing, Dr. Puri, is that, of course, anemia is caused by sickle cell, by sickling, but there might be other things. There is nothing to prevent that patient, especially he is from South Asia, from having iron deficiency or vitamin B12 deficiency. So the nutritional optimization has to be done. Dr. Puri also says that patient with edema, it was bilateral edema. So cellulitis can be ruled out, perhaps. DVT also, the
Yes.
chances go down. Now the question is, can I give intravenous Lasix? What is the risk of hypokalemia?
Yeah, so you can, of course, give IV furosemide. There is no problem with it if the patient is decompensated and having heart failure. But as you mentioned, ejection fraction was normal, and patient has got bilateral edema. I think a Doppler would just surely tell you whether dealing with a atherosclerotic peripheral arterial disease with an occlusion and edema is because of that, or you're dealing with a diastolic heart failure, which is very less likely to present with edema. And I would surely be interested in knowing any drugs that the patient is on which can cause edema, like calcium channel blocker, pregabalin, which may be given for a pain relief, or a glitazone. Is diabetic. So these are the common three things that we see in our outpatient. Patient is on glitazone, or a calcium channel blocker, or a pregabalin. These three things you must rule out. Other drugs, the list is long, but these three you must rule out in the current clinical scenario. These may be responsible for edema with a normal ejection fraction, as you mentioned, along with an ECG, because diastolic heart failure is pretty unlikely to come with it. If that is the case, just stop the drug and the edema will disappear.
And another drug which you might have been using because of diabetic foot, that is cilostazol, which again is a major cause of edema. So if
True.
it is cilostazol, we can stop that for some time. Okay, and for that patient, yeah, ACS, if it is established ACS, then certainly SGLT2 inhibitor and metformin right at the beginning. And if patient is already on them, then you can also add the DPP4 along with it. If glucose levels are high, no harm in adding a modern sulfonylurea, low dose, like glimepiride or glyclazide, sustained release. So we've had lots of questions, Dr. Kamal, and one thing I would like to commend you for and appreciate you for is your 360-degree approach. Not only cardiology, not only heart failure, but the entire science and art of medicine put together. And
I think that perspective holds true for you, Dr. Kalra, as well. The way
no,
you
for
cover topics and
everybody who has joined. When you see the questions from Dr. Rath, from Dr. Desai,
yes.
from Dr. Sanjeev Puri, what it shows is that everybody from Dr. Anshul and Dr. Altaf Chima Sahab, what you see is that everybody is trying their best to manage diabetes, manage the patient as a whole. When Dr. Javed Khan talks about knowing how much iron there is in blood, how to decide between BT and IV iron, when people ask about IV iron versus oral iron, like Dr. Nitin, what it means is that everybody is actually considerate, thinking about the patient's needs. And I'm very sure that if we are all in this journey together, certainly we will overcome. We will be able to achieve a much healthier, a much happier South Asia. From my side, I would like to thank everyone for logging in today. Like I said, it's Sunday evening. So many other things we could have done. We acknowledge Dr. Kamal's expertise and time. And
Thank you
Mr.
very
Karan
much.
Sharma from FDC has been our host for today. A very kind host, I must add. So perhaps Karan would like to give a vote of thanks for today.
Thank you so much, sir. In fact, a metal with such small prominence, iron, has so many implications in so many different branches of medicine. I am thankful to Dr. Kamal Sharma for joining us tonight to enrich the Iron Talks on a very important topic, anemia and heart. And this was an exciting session where I thank you on behalf of our audience, where you have not only brought your clinical expertise but also so generously shared your sound and vast subject of knowledge. I am, in fact, thankful to Dr. Sanjay Kalra for roping in such an eminent doctor for an apt topic, which has done a lot of justice to what we want to serve in Iron Talks. Sir, thank you for being a part and sharing all that you've shared tonight on the Iron Talks session. I thank each and everyone who has joined in tonight for this session. Jai Hind.
Jai Hind.
Thank you, everyone. Good night, Jane. Bye bye.